the where we're looking for rhythms, whereas 12 lead is where we're looking for geography, right? So the best thing about the 12 lead EKG is it gives you more views, more views of the heart. Radiology, we have a saying that one view is no view. Because if you only have one view and the entire hand can be shifted off of the wrist, but if you're only looking at it in this plane, you can't see the fact that it's completely out of plane the other way. So 12 leads give you that multiple perspective. So sometimes that's useful for rhythm, right? If you think you're looking for P waves and you don't see any, but now you look at more leads and okay, I do actually see some. So probably the P waves are just isoelectric to this axis that I'm looking at right now. Versus if you, hold on one second, let me just fix my mouse here, hopefully. Maybe. All right. I'm going to just boot up my laptop to be able to do this here. So if you're looking at the 12 lead, you get those additional sort of views of the heart. So we really, though, this is in the context of ischemia. So looking at, is this anterior wall? Is this inferior wall? 3 lead gives you a really great sense of the rhythm of the heart, P, QRS, T. But the 12 leads really where you're going to get your geography. So I think that if you're if with my approach to the 12 lead, I have a pretty my first step is take a quick look at everything, right? So you kind of glance over it. Does anything catch my eye? And then sort of a more systematic, especially if I don't know what it is right off the bat. If I'm looking at somebody who's sweaty and clutching their chest and gray and good, goes to the jaw. And I see a big tombstone sort of ST segments, that's, those ones are pretty easy. It's really when you start looking at it and go, what rhythm is this? Like, I'm not even sure, like, is this a bundle branch block or is this ischemic? That I sort of break down, into stepwise. So I like, rate, rhythm, axis, ST segments, sort of approach to it. So like, is it, is this fast or slow or normal, right? Is this above 100? Is this below 60, below 50, or is this a reasonably normal rate? So my, sort of gut look. So everyone, did you guys learn the 300, 150, 100, 75, 60, 50 trick in terms of counting the boxes? Do you guys know what I'm talking about when I say that?
Yeah, I believe we did. You're talking about lining up the R waves, trying to find one that's kind of on the line, and then counting your way down through the squares.
Yep, exactly. Right. So that, so sort of roughly, that's exactly what I'm talking about. So, getting a rough sense of like, is this, I can estimate the, the rate there. And then, then looking at rhythm, right? So like if you want to, sinus rhythm, find a QRS, is there a P before it? Is there a P before every QRS? Or are there some QRSs that don't have Ps, or are there some Ps that don't have QRSs, right? And so those sort of like first initial look at the rate, then the rhythm, and then from there sort of you can really rule in or rule out a lot of bad stuff. So a lot of this though we can still do just with the rhythm strip. When we start talking about axis, that's where we start needing the 12 lead to sort of look at that geography. So I don't think it really matters all that much in terms of uh, do you get is the axis 30 or 60 or 75, right? The specific numbers aren't really key. Some of the things you can do with the axis are, one, figure out if you have the EKG on, right? Like if you get an axis, if your axis looks like, AVR is the largest upright lead, your first instinct should be, I bet you I have a leg and an arm switch or something like that, right? If your axis is wrong, a very common cause is that you have the leads mixed up, and that's, that happens, right? You and your partner are working together to put them on, and something gets crisscrossed. And so, but being able to sort of quickly glance and say like, okay, is it upright in lead 2? Is it upright in lead 3? Is it upright in lead 1? Okay, it's probably this axis is roughly normal. And being able to do that somewhat quickly, is I think a worthwhile skill. But really, the money is in the ST segments, right? That's really where we're looking for our for our ischemia. So are are you seeing, I don't need to go over the details of the geography with you, but like, are you seeing inferior wall? Are you seeing anterior wall? Are you seeing multiple areas where it's like, this doesn't make sense? This 35-year-old guy who had, a cold 3 weeks ago can't possibly be having a STEMI in every lead, right? Like, it can't be an inferior and anterior, and he looks pretty good. He's just complaining of some chest pain. Okay, well, maybe this is pericarditis. And so, like, being able to sort of put that look at those in that clinical context. Um, and then, intervals. So, really figuring out, like, are the QRSs the right duration, ST segment, or sorry, your QTC, is the T wave less than half of the RR interval. And so being able to go through all that kind of stuff, relatively quickly. And the more you do it, the faster you get at it. So, like, if you approach it with that systematic approach, you get faster. And then the last thing I do is kind of look for the specific things that I might be concerned about that an EKG might tell me in that patient, right? So if you're seeing a patient who is showed up to dialysis, and they decided not to dialyze them because they're short of breath, what might you be specifically trying to find on that patient's EKG?
In T waves.
Yeah, exactly, right. So, like, do they have huge, they have peak T waves, looking for the potential that they're hyperkalemic because they haven't been dialyzed in a couple days. If you have a patient who overdosed on antidepressants, TCA, tricyclic antidepressants specifically, let's say, anybody have a guess what finding, or know what finding you might be looking for in somebody with a TCA overdose?
Would it be prolonged QTs?
So it doesn't usually do QT first. It actually usually does QRS first. So we'll start to see interval widening of the QRS, and that actually, they blockade the sodium channels. And so there's a number of meds that can do that. Lidocaine overdose can do that. TCA overdose, a number of different meds. But when we start to see interval changes from overdoses, that worries us a lot. So pretty much every overdose patient or alleged overdose patient, even if somebody comes in and they say they took, 3 Xanax, and we know that's probably not a lethal overdose, pretty much all those patients are going to get an EKG as part of their workup, because we want to make sure, one, are they being truthful with us, and two, is there a potential that they're having cardiovascular toxicity from whatever they overdosed on? And so, thinking about a 12 lead, not just in the sense of ischemia, but also, what can it tell you about the electrolytes, in the cardiovascular system, right? So we see hypocalcemia, hyperkalemia, hypokalemia, all of those things can have sort of classic EKG findings, as well as we don't really see the blood sodium in EKGs, but we can see medications that have effects on sodium channels, like opening them or blocking them. So, I'm gonna just I need to pull this up on my laptop here I'm having some issues with my office computer loading the questions here. So yeah, so that's sort of how I approach it. Does that help, or does anybody have questions or want to discuss sort of their strategy on approaching 12 lead?
I do kind of a follow-up question to that. It might be a little kind of off topic a little bit
Yep.
here. Yesterday I was talking with Dr. Alvin Wong about EKGs,
Yeah.
and the topic of the posterior EKG came about. So I just kind of wanted to get your thoughts on when we're actually putting on. I mean, is that something that we'll do in the pre-hospital setting, where we're actually setting up the V7, 8, and 9 on the posterior if we're not seeing? Do you tend to go towards it if we're seeing signs of MI, but we're not necessarily seeing it in the standard leads, or
Yeah.
like if we're seeing depression in weird places?
That's a great question. You're right. So both posterior and right-sided EKGs, I think, have utility, but it's pretty limited. Like, I'll tell you that somebody working uh, in a high volume cardiac cath center, like Einstein Philadelphia, Einstein Montgomery, between the two, we see, like, probably about 150,000 patients a year. And I can't remember the last time that a posterior or right-sided EKG changed my clinical management for a patient. So there's times when I've been suspicious that somebody was having a posterior infarct, because they had ST depressions in V1, V2, but they looked really, really sick, and get a posterior EKG and lo and behold, it's positive. But usually you're confirming what you already believe with that. Same thing with, if you have somebody with an inferior wall MI and you decide to throw right-sided leads on, you are going to probably, potentially confirm that, yeah, hey, there is right ventricular involvement in this because they have right-sided ST elevations. But you usually already suspected it. And I'll say that in the era of ultrasound, if I'm working up one of these patients in the ED, if I am suspicious, I'm just getting the ultrasound and I'm looking to see which part of their heart isn't beating right. And it's a lot easier to diagnose right ventricular involvement by proving that the right ventricle isn't beating right, very well than to try to try to get it electrocardiographically. So I'd say that it's unlikely that these would change your management all that much in the pre-hospital phase. But if you have the bandwidth to do it, right, this would be something I wouldn't sit on scene probably working on. If you have somebody who's looking like they're having an infarct, I would shoot your standard 12 lead. If it's negative but suspicious, I would probably send it and call ahead and start having that discussion and maybe say, hey, look, en route, I'm going to set them up for a posterior EKG. I'm going to try to grab it at a traffic light or convenient stop or something. But I wouldn't necessarily let that it's very unlikely that's going to change your decision making. What did Dr. Wong have to say? I'm curious his perspective.
Yeah, so he was definitely kind of mirroring the same thought processes there. He said it's a great tool to have in the ER where we're kind of in a more controlled setting, right? We're already at that sort of definitive care level. And he did also say it's not really necessarily going to change your route of treatment in the pre-hospital setting. We're still going to be going for our aspirin treatments. We're still looking, calling medical command, considering nitro and everything like that. Obviously, oxygen, continuing 12 lead transmitting. But he did also say that that's not really something that you want to get too much into the weeds about when it comes to like delaying care to go about doing that. Because again, once they're in the ER, that's something that's going to be done again.
Yeah, exactly. I think that's we're aligned there. All right, let me hit a couple of the easy sort of shorter questions, like shorter answers, and then that way we have some time at the end to have more discussion with things. So I have I have a hard stop today at 4. I'm working clinically in the ER, so I got to walk up the hill. So I got a hard stop at 4 o'clock today. With regards to there was a question about scenario from class. This is from Alan, a patient experiencing CHF exacerbation as well as STEMI. What's the proper order to assist the patient to deal with CHF first, STEMI first? Can you do both simultaneously? And I think the answer to this is that you're going to do both simultaneously. So the CHF most likely is from the STEMI, right? So if you're having a STEMI, you have blockage of one of those arteries. Part of your heart now is not moving. So that's really where that's where the ST elevation comes from. It's funny, I don't know if you guys talked about this in class at all, how deep into the physiology weeds you've gotten, or maybe you some sort of extra reading on the topic. But when you have a STEMI, that part of the heart becomes electrically neutral. So in fact, we might think that the flat part of the EKG, right? So P, QRS, and then the flat line, we often think of that as like 0. On the EKG, at least I in my head think of that as 0, but it's really not. That's actually when the heart has been repolarized. The battery, so to speak, the electrolyte battery has been recharged. So when you have a STEMI, the reason that you have ST elevation is in fact the only time that the heart is completely depolarized is during that ST segment. So that's really where your 0 point is. So when you have the dead part of that heart muscle, the part that temporarily or permanently isn't getting any blood flow, that's causing a current leakage. It's like a short, like a leak of current from there to the live heart the rest of the time. And so that ST elevation is actually the 0 point. And the rest of the time, what you're seeing is we call current of injury, where it's actually leaking to the healthy heart. And so it's interesting, that when we look at MI with ultrasound, if we look at if somebody's got V2, V3, V4 ST elevation, and you put an ultrasound probe on their heart, that anterior wall is not going to be moving. So the heart's squeezing normally, right? And then if there's the anterior walls out, the anterior wall, my fingers being that part, are going to stay still, right? So instead of coming in, it's just still. So the heart, you lose some ejection fraction, right? And what's CHF? But it's just a lack of good ejection, right? So it's either a filling problem or a pumping problem. In this case, it's a pumping issue. And so their CHF is from the STEMI. What's the best way to treat it? It's to get that blockage open. So I might not necessarily treat them with all the same stuff, right? If their blood pressure is labile, maybe nitro isn't the best option for them, but it still could be if their pressure is tolerant of it. It actually might be the best thing to offload that heart a little bit. Certainly, aspirin you're going to be doing in parallel. Getting them, getting the cath lab activated is the most important thing. So the faster you can get that 12 lead done and get the cath lab activated, the better they're off they're going to be. Big belief of mine, and I've gone toe to toe with hospital on this in the past week. One of our major receiving centers to say that they told one of our crews, hey, look, we're not activating on pre-hospital STEMIs anymore until the patient is here. I said, look, that for us that's not acceptable, right? We can't. Our goal is to get to that patient's side and do that 12 lead in their house or in the nursing home or wherever they are. If we are bringing that 12 lead so far forward, we're doing it in their living room, and then we're calling you to activate it before we even move the patient to the ambulance so that we can give you a 20-minute ETA, and then you're not going to bring that cath team in. So now now you're telling us that we are at patient's side at 3 p.m. EKG's done at 3:05. The cath lab call is at 3:08. We load the patient at 3:15 and we have a 15-minute drive and we're at the hospital at 3:30. You had 22 minutes to bring that cath team in to do this, and you decided not to. But hospital B is 10 minutes further. So they were going to be there at 3:40, but the team is there, and in your case the team isn't going to be there until 4 o'clock. We're going to hospital B. We're not. Our goal is first medical contact to balloon time. It has nothing. I don't care who's closer or whatever. I mean, certainly if the patient's unstable, but those are conversations that I'll have every day with a hospital to say, like, this is, our goal is to activate. We're gathering this data so that you can do something with it, not so that you can, not solely that we make the right decision for a destination. So I see some questions there. Sarah, I think.
I was on that call. That
Okay.
was our call.
Yeah.
What would we have done differently? Because I saw your QA where it was a demand MI. What is that? Like, how would we recognize that in the field?
Great question. Yeah. So I'll just briefly, for everybody to sort of have some context here. So this was a patient who had ST changes. Definitely, met the criteria for ST elevation. However, the patient's presentation was a little different. They were, and Sarah, correct me if I'm misunderstanding anything from the chart versus what you were actually seeing, but it sounded like the patient was decreased level of responsiveness, sort of like I'd say altered mental status. I don't think totally unresponsive, but maybe responsive to pain initially and then
We
verbal
got
stimuli later.
dispatched for an unconscious.
You got right, going out as unconscious.
And she was like in and out of it, but she said like she could tell you things, but she was also like not there.
Right.
Like we had to ask her 4 or 5 times if she had chest pain, and then she'd be like, yes.
Yeah.
And then she would describe it.
But then her blood pressure was pretty good. Like in the 120s, 140s, I think typically for most of the call. I don't think she was ever hypotensive. Her heart rate was reasonably normal. It was in the 70s or 80s, if I recall. And so what that to me is, so why would somebody be altered who's having an MI? So the main reasons are they're not perfusing their brain. So I'd expect that in that case, the blood pressure would be lower, or there would be more other sort of signs of cardiogenic shock present, or they potentially are in such severe pain that they are, that they're unable to sort of like can participate in the exam, right? They're like the crying, moaning, like unable to sort of overcome that pain state, right? And so this patient didn't really sound like that. And so I think ultimately this patient was wound up being diagnosed with sepsis, and I was treated as such and improved with some antibiotics, fluids, and things over a couple days. Did get a catheterization, did ultimately get a cardiac cath, and had clean, no blockages in the coronaries, right? And so what a type 2 MI or demand MI is, if you have narrowing of your coronary arteries, not a blockage where you have like a clot in it, but just stenosis or narrowing, and you now do something that stresses your heart. So a stress test is basically you're running on a treadmill or you're giving somebody medicine to make the heart have to work. And while they do that, they do an EK or a 12 lead, continuous EKG. And if you're running on that treadmill and you have a 90% lesion in your LAD, by minute 6, 7, 8, you start to see ST changes. And that's how the stress test works. Then they do a nuclear piece after it where they give you some dye and look for uptake and things. But really the first part is just let's exercise and see what happens to your ST segments if you get depressions or whatnot. And so that's basically what I think was probably happening to that patient, is they were just older with extra demand from their sepsis, and that was causing the ST changes that we saw. You fix it with fluids and everything else, and the ST segment should come back to normal. And so it's interesting because we don't usually see it as elevations. Like a STEMI is a weird way for that to present. But it met the criteria. It was more than a millimeter of elevation in the inferior leads. It met the criteria for STEMI. They did take the patient to the cath lab. They did prove that it wasn't a blockage, but so that's really that's really one of the ways we diagnose a type 2 or demand MI, is by proving that it's not a clot, but through catheterization. So, in that sense, I don't. There's two things with this call. One, I don't disagree with anything you guys did, and I don't really disagree with anything the hospital did. I think it's reasonable to slow play that, in that context. However, the comments that the hospital made that they weren't activating pre-hospital was what I really needed to clarify with them, and I think there was some misunderstanding there. But that, I say all that to say that, like, this is something that we will absolutely advocate for our patients, that we want to do early 12 leads so that we get this data early. But if the hospital is not going to act on it, we need to factor that into our decision making, because we want to get our goal is to get that patient into a cath lab as quick as possible, not necessarily to get them to a certain hospital wherever they can have that done the fastest. So just to finish up the CHF question, I think you're going to kind of do both. Your treatment for CHF may need to change based on the fact that the heart is not going to respond as well to some things because it's ischemic. But I think that's BiPAP if you need, or CPAP if you need it, certainly reasonable. Nitro if the pressure will tolerate it. All those things are sort of on the table. So I think you're kind of doing both. Question?
Yes, thank you, Doctor. This is a little bit of a simple one for you here. In regards to the ST elevation and obviously when you're seeing possible MI and the EKG, how would you, as a receiving provider, like to receive that notification? Like how should that properly sound for you? Because we've definitely done a lot of talking about how to identify, but not really how to call it in necessarily.
Yeah. So I'll give you some examples, right? So I think a good call would be, let's just say you show up to a gymnasium. There's a bunch of old guys playing basketball, and there's a guy sitting on the bench who got some chest pain. You walk in, you start talking to him. He looks gray and ashen and sweaty. He says that, I was playing for about a half hour. I didn't feel great when I started, but now my chest hurts. It goes to my jaw, my left arm, having some trouble breathing. I think our goal would be get him, not put him in the truck, not do anything else until you do that 12 lead, right? So the first step would be getting, routine vitals, getting that 12 lead on, potentially getting IV access right there, potentially considering even putting the pads on them, depending on what you see on that 12 lead, right? Because these are patients who decompensate quickly, and unexpectedly. And so the more data that you can have, if he's having a STEMI and you can diagnose STEMI, and then he arrests on you while you're moving from the gym to the ambulance, versus if you decide just to scoop him and walk him out, and he arrests on you and you never diagnose STEMI first, his care down the line will be dramatically different. It is really easy to convince a cardiologist to take a patient to the cath lab who had a diagnosed STEMI before they coded. It's really hard to convince someone to take someone to the cath lab who has, even if they have ST elevations after the cardiac arrest, and this guy probably not, but like other patients, if you don't have that data, they're going to go, well, what if it's something else, because it's not a, but it's a, it's a procedure. They don't want the patient to die on the table. They don't want to do an intervention that's going to be, taking away from their ICU care, ventilator management, et cetera. So it's really key to get that 12 lead early. So then the call, I would hope, after that, it would be like, hey, I'm calling, medic 345, inbound to your facility with a patient with a STEMI, 45-year-old guy, whatever, the 55-year-old guy playing basketball, developed chest pain, radius to his jaw and his arm. He's complaining of shortness of breath. And 12 lead shows ST elevations in V2, V3, V4 with reciprocal changes in 1 and ABL. His vital signs are, whatever they are. He's gotten aspirin, 2 nitros. His pain is still a 9 out of 10, and our ETA is 12 minutes, right? You give that report, I don't think you're going to have anybody questioning what's going on or whether you're doing the right thing or not. If you can transmit an EKG, I think almost everywhere in the world now has, or at least in the US, has ECG transmission capabilities. So if we can transmit an EKG, that usually helps. At 3 p.m., it's not hard to activate the cath lab because they're all there. At 3 a.m., it's, a cardiologist is going, am I going to page out 4 people and, have them all drive in from home in the snow? For a patient who's having a heart attack, it's a lot easier for them to make the decision when they have that 12 lead in front of them, and they know it's not pericarditis or an overcall or, a left bundle or something like that, where it's, we know the patient always has that rhythm or something. So, yeah, I think that's how I would play that. Does that answer the question?
Absolutely. Thank you.
Yeah. Okay, pre-hospital fibrinolytics. So I think, right now the gold standard for STEMI is catheterization. I think that the role of fibrinolytics, even in the hospital, is pretty minimal. We don't lyse people in the hospital unless there's real delay in getting them to a cath lab, like if they're at a hospital with no cath lab, or if the cath lab's out of service, or all the cardiologists are committed, or something like that. In those cases, we do fibrinolytics, but it's a pretty rare, it can make the cath more technically challenging because now they're like at risk of bleeding, and so they could bleed from the puncture sites and things. So, aside from all the other complication risks like bleeding in their brain or developing hemorrhagic pericarditis or anything, right, because the heart's dying and inflamed. And so if you give them something that causes their blood to not clot, they can start to bleed into their pericardium. And so we really don't like giving fibrinolytics for STEMI unless there's a real delay to cath. So I say there's not much of a role for pre-hospital lysis. Just in general, our time is best spent getting them there. Alan. See your hand
Thank you,
up.
Doc. So the thing is, I sent a second question, but I didn't see it on the list. So
Okay.
since you are answering my first question, I would like to ask you the second one real
Sure.
quick. So the second one was, let's say a medic is running a code and mistakenly we shot a asystole patient. We all know it's a no, but let's say that happened. So in that situation, can we say that the outcome of that patient is compromised if the medic do so?
So I'd say that if you shock an asystole patient, it's unlikely that it's gonna I mean it's unlikely to be harmful. I mean it's certainly it's the biggest harm is probably that we're doing things that aren't gonna help, like we're pausing CPR. it's unlikely to help, right? If the heart's not fibrillating or not in a dysrhythmia and it's just asystole, a defibrillation or cardioversion is not going to change that rhythm much. It's exposing the heart to additional electricity. It's exposing, but mostly probably the downside is just that you stop CPR for 10 seconds. So I think I wouldn't, if you, let me say it this way, maybe this is what you're asking. If you're not sure if it's fine V-fib or asystole, call it fine V-fib. If you think, I think this is fine V-fib, but I'm not, but it could be asystole, call it fine V-fib. I'd much, much, much rather you shock asystole 2 or 3 times before you realize that before it's clear that it's definitely asystole, then look at a post event monitor strip and go, shit, they've been in but they've been in VFib for 10 minutes with no shock, right? Like that's a much worse uh that's the definitive treatment is not available, right? So I don't know if Alan, if that's what you're asking, but that's my sort of take there is err on the side of it being fib if you're not sure.
Thank you.
Yep. And I'll defend that every day of the week there. Okay. Next, there's a question I think that's worth getting to about Lucas. I know this isn't exactly, this is a not 100% the topic here, but the role of mechanical versus manual CPR. So all of the evidence out there suggests that manual CPR is as good or better than mechanical CPR. So this belief that like getting a mechanical CPR device on is going to improve the outcome has no evidence to support it. The best studies have shown that it is no worse. I'd say the most favorable studies have shown that it is no worse, but no study has ever shown that it's better except in one circumstance. Does anybody know where the one circumstance, the one I may just say the one patient location where it's been shown to be superior? This is kind of a guess what I'm thinking question because I can think of another answer, which is transport. I'll talk about that in a second. But the one time that it's been shown is in hospital. So patient on a big fluffy hospital bed, even when you throw a CPR board underneath it, manual CPR is not all effective, right? And for whatever reason, we don't typically yank people off their hospital beds the way that we do in the EMS. So if you have a patient on a bed and you can't get them off the bed, it's one time that if I would consider if you don't believe your impressions are effective, flipping to mechanical CPR earlier. But the real answer to this is that it's definitely better when you're carrying a patient anywhere, rolling a patient on a stretcher anywhere, or driving in the ambulance, right? So if you're carrying the patient down the stairs in the Reeves, it's definitely better to have a mechanical CPR device on the patient than stopping at every landing, and having 30-second no float states, right? So that's the clear time when the mechanical CPR wins. If you are driving, from a safety perspective, it's clearly safer. And so I think, it's with running a code with a ventilator and a mechanical CPR device. We're not quite there yet in Pennsylvania where you can use ventilators in codes, but we're getting close, I think, as the vents get better and technology is there. But like running a hypothermic code in the ER with where you put the patient on a mechanical CPR device, have them on a ventilator, and give them vasopressors by infusion instead of by push, it's almost like you could leave the room because there's nothing to do, and so I think that for transport, for sure, it's safer. You can have your seatbelt buckled while you run a code, which is just, I think it's such a huge advantage. And then if the team is tired, I think that's another real opportunity there. But my goal when I'm on a cardiac arrest is 10 minutes of hands-on CPR. At least 10 minutes of hands-on CPR before you think about switching to mechanical, because the evidence is just that it's probably better. We probably do better compressions, especially with a feedback device. We're probably going to do better hands-on compression. So, and comment.
Yeah, sorry, I don't want to monopolize all the questions here.
Yeah.
That's so when it comes to like the in hospital care when we're doing codes and everything, uh, let me kind of rephrase this here. With the influx of technology that we have going on now, right? So obviously with VMSC, with our employees, a lot of our ALS units at least have those butterfly ultrasound devices on it.
Mhm.
Is it something that we're kind of moving towards now? Where I know in the in-hospital setting, a lot of the times when we have things like we're dealing with PEA and we're not necessarily sure if there are contractions, whether the pulse is very weak or whatnot, is it something that we can consider looking for that contraction with the ultrasound when we're doing our codes to ensure that there is actually contraction with this PEA or whether it is actually true PEA?
Uh, yeah, yes, but not yet. So the state has not yet given us carte blanche to do or teach whatever we want with ultrasound. So we are working on a really limited use, which is pilot that they did approve on looking at thoracic ultrasound. So definitely my hope, if they will accept my ultrasound protocol for the 2025 update, is that we will be able to define which ultrasound indications we want to use in our squad, and cardiac arrest would be one of the first ones that I would add. Because I do think that there is value in prognostication, looking for cardiac squeeze or not, as well as looking for causes of cardiac arrest. Is there tamponade? Is there attention pneumo? Things like that. So yeah, so I think it's definitely coming. Any other questions or comments specifically on mechanical CPR with this? I'd happy to talk about it, but if not, let's get on to um, uh, the cardioversion defibrillation stuff. Because there's a couple good questions. I don't see any other questions there. So a couple good questions on tachybrady stuff and the definition of shock in terms of when to sort of switch to electricity versus drugs. So let me first start talking about there was a question, the difference between cardioversion and defibrillation. And so I think this is a really interesting question. The difference, so if a lot of this, let's just talk about the semantics first. If you are writing your chart, you show up on a patient and they have pulseless VTAC, and you shock them, and they now have sinus rhythm with a pulse. You've cardioverted them, right? That's the term for that. Even if you defibrillated them, even if you pushed it didn't sync, you delivered a unsynchronized cardioversion. So defibrillation and cardioversion are the same idea. You're applying electricity. A synchronized cardioversion means you're attempting to time that based on the cardiac cycle, versus an unsynchronized cardioversion, which is defibrillation, which means you're not trying to time it. So if the heart is fibrillating and you cardiovert it, you've defibrillated it, and so it's whether that's VFib or AFib. So some of it is just terminology. So I'd say this: why do we synchronize cardiovert when somebody has a pulse, and we don't synchronize when they don't have a pulse? And really, the answer to that is to prevent delays in treatment, right? And that's we know that there's R1T phenomenon, things that can happen. But our goal is that synchronized cardioversion, we can take the time to make sure that we minimize those risks. Whereas if they are pulseless, it just, we don't want to even spend the time to try to let the machine sync, because sometimes it won't shock right away. You'll push the shock button and it won't shock, and then you might have to unsync, and then shock if it doesn't have a good sense of where the cardiac cycle is. So I think that's the sort of the answer to that. It's kind of it's basically just about time. But defibrillating and cardioverting functionally are the same thing. Torsades, there was a question about torsades as why is torsades a form of polymorphic VT rather than a variant of VFib? And it is a interesting question. So when we think of torsades, we think of, I think it's in between those two things. So VFib means that there is no organization. Each cardiac myocyte decides when it wants to depolarize, and it's relatively uncoordinated. if you have a region of the heart that's kind of defibrillating together and another region that's kind of fibrillating together, you can have some sort of maybe there's coordination, maybe there's a pattern to the VFib, but it's still fibrillating. Versus if you have VTAC, that could be either a coordinated tachycardic response or it could be one myocyte that's stimulating the whole heart. So it's coming from the ventricle and it's traveling across and it's only a ventricular rhythm and it's tachycardic. If it's pumping blood, it would be pulse, VTAC with a pulse. If it's not able to generate enough pumping action to generate a blood pressure, then it's pulseless VTAC. So it's just about how coordinated it is, maybe where it originates. Torsades is somewhere in the middle. Torsades is a rhythm where the heart is that stands for twisting of the points, but basically what it means is that there's like a circular activity usually. So instead of depolarizing from here, this cell, which causes enough of a coordinated activity to squeeze the ventricle is kind of depolarizing in a circular way. So like it's traveling around almost like a plane flying around the globe, right? If you think of it's like and so it doesn't really generate forward blood flow, but it's also not completely uncoordinated like VTAC. And sometimes that can stay on one axis continuously, kind of like a flutter does often. It's just one continuous axis as it spins around. It doesn't really depolarize in a pumpy sort of way, but it's a very regular depolarization. Torsades can either do that or it can sometimes take different courses around the heart, and so that can change how quickly it changes there. So it doesn't really matter because it is we think we consider it a type of polymorphic VT, but in reality, it's almost always a non-perfusing rhythm. It's very, very, I can't think of ever seeing torsades in a patient who had a pulse. It's almost always a pulseless rhythm. The question about it should you try to synchronize cardiovert versus defibrillate? Almost always you're going to see it in a pulseless rhythm, and so it's not worth attempting to synchronize. You're just going to I don't even know what the machine necessarily would try to sync to. So it would be I think it would be worth considering just as a pulseless rhythm. Does that make sense? That was Jack's question.
Yeah, so would it be just like fair to compartmentalize like torsades is basically like this VTAC is gonna be, you know, uh, fibrillation pretty quickly, and
Yeah.
it's just like maybe like a middle point between the two.
Yep. Yeah, I think it's a middle point between the two is a good way to think of it. The most important, so the reason to recognize torsades is to remember that you potentially, in addition to giving your other antidisrhythmics, potentially could give what other drug?
Ag.
That's
Yeah,
what we're
right.
considering mag.
Yeah, so magnesium, right, would be something you would consider if you saw torsades, because it often has an electrolyte component. The most important thing, though, is to remember that the treatment for torsades is not mag, it's electricity. And I say this like you guys all probably think that that's a obscenely silly comment to even make. But I will tell you that we run mock codes in the hospital on the floors and have physicians who do not run codes a lot. They, like internal medicine and other people that have to do, ACLS training every 2 years. And they get that wrong. They give 4 grams of mag and do CPR and forget that torsades is a fibrillation, a shockable rhythm, right? And so I say that only to remind everybody that torsades is first and foremost a shockable rhythm. The fact that it has an adjunct treatment of magnesium does not mean that it's the only treatment. And I say that joking, but not, because it's easy to forget. So if you remember nothing else, remember that torsades is it's a shockable rhythm. It's not just treated with mag. Okay, so running low on time here. I want to try to get to some of the other questions here with pacemakers. I think pacemakers. The key to pacemakers is I think a couple things. One, thinking about what is it doing, right? So there's many different types of pacemakers out there. If somebody has a pacemaker for bradycardia, it might it may be a sensing pacemaker where it's able to have a lead in the atria and try to sense the rate that the heart is attempting to beat and then pace the ventricle at that rate. If it doesn't have a sensing component, most modern ones do, or it might just be set to be a rate of 80, right? Some people with maybe like POT syndrome or something may have a pacemaker that just has a floor rate. So as long as the heart's beating at least 50 times a minute, it doesn't do anything. It senses 50 beats a minute, and then if it goes less than that, it'll just start pacing at 50. So it's there's many different types of pacemakers out there. If you're working a code in a patient with a pacemaker, what do you need? What do you need to remember about it? What are some of the things you've learned about codes and pacemakers?
Don't put the paddle over the pacemaker.
Correct. That's a huge one. Don't put the electrodes over the pacemaker. If you're the other one is what does everyone heard about using a magnet on a pacemaker? Is that necessary? Do you have to do that? What does a magnet do to a pacemaker?
I think it like deactivates it.
Yeah, so it depends on the pacemaker, right? So this is a pacemaker magnet. It depends on the pacemaker. I don't have a pacemaker, so I'll just well, this is not hurting me, promise. So if you put the magnet over a pacemaker, it will, if it's a defibrillator, usually the action is turn it off. It's designed to give you a way to stop delivering inappropriate defibrillations to a patient. If it's a pacemaker, usually the action is to set it to demand mode, typically with like a backup rate of 70 or 80 beats a minute. So let's say their pacemaker is not working because it's not sensing. It thinks that the heart is beating normally. And so it's like, I'm not pacing. But meanwhile, their heart rate is 30. If you throw a magnet on that pacer, it'll probably flip it to a rate of 70 or 80, and then the patient will feel better. You don't have to do anything with a magnet in cardiac arrest. Even if you're pronouncing a patient on scene, some people would say, well, how do you pronounce it if the pacemaker's still on? If the pacemaker's still on and they have just those blips, a spike, not a QRS, but just a spike, nothing you need to worry about there. That's asystole with pacer spikes. If the pacer is still on and they have QRS complexes, that means their heart's still conducting electricity. And I would have a lot, that's PEA, and I would have a lot different thought about pronouncing a patient with that happening. So when you're interpreting a 12 lead in the patient with a pacemaker, it gets really complicated. Scarbassa criteria and all of these other things. I don't think I would spend a ton of time or brain power remembering those rules. I don't remember those rules. If I need to know it, I look it up. I look up the millimeter criteria and everything like that. In your setting, I would lean more on your clinical impression. If you have a patient with a pacemaker and an ugly looking EKG, and you don't really know if it meets the criteria, look at the patient. They're very sweaty, clutching their chest. Err on the side of transmitting that, calling ahead and saying, I think this is ischemic. If they are, if they had an ugly looking EKG and they called you because their nose is stuffy, it's probably just an ugly paced EKG, depending on where the lead is in their ventricle. Defibrillator, different question. So defibrillators have leads that are placed internally to shock the patient, so out of an abnormal rhythm. If you have a patient whose defibrillator is firing, as the nature of their call, the instinct should not be to turn it off. The instinct should be to assume that it's shocking them out of some life-threatening rhythm. And so, magnets, I only would put a magnet on to turn a defibrillator off if we're positive that they're not having brief runs of dysrhythmias. And so, I would probably err on the side of fentanyl transport, and then let's get like 20, an hour worth of data before we start deciding that the device is wrong, because these devices are really sophisticated. They're right a lot of the time. They might be seeing something that you're not even seeing on the EKG because it's inside the heart. Alan.
Yes, Doc. Speaking of, would you recommend that we transport a patient who is in cardiac arrest and PEA for all the time?
Say it one more time. I had a hard time hearing the last sentence.
Yes. So I said, would you recommend that we transport a patient in cardiac arrest who is in PEA for all the time?
I'm sorry, Alan. I'm just would I prefer if you transport the patient with what?
Pulseless electrical activity.
Well, okay, so PEA, would we prefer? Oh yeah, sorry, thank you. I just my speakers aren't that great here. Would I prefer that you transport the patient with PEA? Um, Not necessarily. But I personally have I often will transport patients or work patients with PEA until the point where I am comfortable that it's actually unsurvivable. And so the 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 way that the Pennsylvania protocol is written, and many state protocols, is it's not that you call for termination of resuscitation. It's that you work the patient for the first 15 to 20 minutes, the life-saving interventions, the attempts to defibrillate, EPIs, airway management, all of that. And then you call for a discussion and a decision together. So if you want to transport a cardiac arrest, if you still should call command and have that discussion. If that's how the protocol is phrased, it's not calling only if you don't. Now, if it's unsafe, if the family's starting to yell at you and threaten you, if it's a public area and there's a crowd gathering, different story, right? You make that call. You don't need to call command. But if it's hey, we've been working this patient in their home with 65 with some medical problems for 20 minutes, you may not know if you want to transport them or not. They might have been PEA for a while, right? And so that's a time when I would call and I would just have that meaningful conversation. Like, hey, my gut is we probably should transport this patient, or hey, my gut is that this is unsurvivable. We haven't seen any response. When I have a command call for PEA, two questions I always ask: fast or slow, wide or narrow. So it's much different having a patient with a narrow complex PEA at 80 than a patient with a wide complex PEA at 20, right? Wide complex at 20, very poor prognosis. Narrow complex at 80 is probably not dead. They're probably just really hypotensive, right? They probably, if you put an A line in, they'd have a pressure of 30/10 or 50/20 or something like that. You can't feel a pulse, but they have one. And so I always consider that in my decision making. And it's worth, when you're talking about PEA, thinking about it differently if they have wide or narrow complexes and fast or slow complexes. So often trauma will see narrow complex PEA with a rate of 120. You can't feel a pulse, the patient's totally out, but their heart's beating 120 times a minute. When we open their chest, their heart's kicking away at 100 times a minute. It's completely empty, no blood in it, but it's beating. And as soon as we can clamp the aorta, give them some blood back, right now it's beating, it works again. And so much different sort of prognosis based on that. All right, I'm running out of time here for the hour. There are a lot of good questions. Are there any other burning questions here? And maybe if not, I could, Paul and I can talk about adding some time the next time we do one of these. Maybe we can loop back on some of these. I think I got most of at least if I didn't answer your question specifically, I think I touched on concepts. Everyone, let me give another quick answer. Epi or dopamine for severe bradycardia. Epi. Dopamine is almost never the answer. It still might be on the National Registry test, but as from a perspective of what vasopressors do we use, it's very, very rarely the drug of choice. It causes a lot of dysrhythmia at the doses where it's having effect, and so it's unlikely to be the right drug. So epi definitely preferred there. Couple questions about devices, transplants, things like that, where if you're not familiar with the device, LVAD transplant, call command and call early. At the hospital, we're going to engage the transplant either the transplant team or the LVAD team. If you call command and that patient's known to us, or even if they're not, and it's a complicated question, we'll probably try to get somebody on the phone even before the patient gets there and let that LVAD coordinator know. And we might even try to get back in touch with you if they have some other recommendations. So LVADs we could talk about, I think, a whole lot there. I think that other questions. Anybody else have anything that they want to hit? All right, Paula, you got anything else that I should hit in the last minute here?
I don't have anything, Dr. Overberger. I really do appreciate the time you take with these guys. That was an excellent, excellent hour we've spent with you, and we really enjoy when you come in and talk to us. So I just want to, on behalf of the class, thank you again for taking the time out of your day to sit and meet with us and kind of go over everything. Because I think they get a great amount of information from you. So it's great that you are willing to share your let us pick your brain.
Happy to do it. All right. Well, thanks everybody. Yeah, we definitely. I'm hopeful at VMSC at least, just for the our regular educational content in the next 2 or 3 months. One of the things that's come up is EKG, so we'll probably have a talk there. So certainly, you guys are all welcome to join us.
Appreciate it, Doc.
Thank you, Doctor.
Yep. All right. Have a good afternoon, weekend. Yep. You got it. See ya.
Bye-bye.
Bye.
All right, guys. Do you all have anything that we need to look at for next week? Is there anything that I need to know about that we've got to get worked out?
Paul, I do have a question actually.
Go ahead.
So I know we were talking about the torsades and the how it is one of the shockable rhythms there, and that our treatment is the shocking. I was just confused, kind of. Then at what point down the line are we doing our 2Gs and mag?
It's really that's a conversation. So when you have that torsades, you see that. Really, you're going to do that in consultation with regional commands. I'm not, or your medical command physician. Not trying to pawn that off per se. It's one of those things you're probably going to have that conversation. You can defibrillate it, try to reach out when you're trying to figure out your possible causes and you're looking at things and you're talking at that point internally, trying to get your IV set up or whatever, maybe trying to get on the phone with your medical command physician and get some feedback from them at that point.
Gotcha. So is it more in the context of like a torsades that's not responsive to defibrillation?
Yes, that is correct. And you're wanting to the thing too with that is they don't understand how magnesium sulfate really works to correct it. They just know that it does.
Gotcha. Okay. Thank you.
I think that's why you see like less emphasis on it. As he said, where you're going to defibrillate, you're going to worry about the defibrillation first. Oh, Lord have mercy. Sorry, we're in traffic here at Raleigh, Durham, and it's a little chaotic. But is there anything else? Do you guys enjoy this time when you get with the doc?
Very much. I think it's a great resource to have.
Good deal. Okay. All right. So everything should be online and ready for you to start working on. Isn't this week our test prep week where we're getting into review? I think we're going over cardiovascular emergencies.
I know for lab, I believe in the coming week we're actually going to be doing our ACLS first.
Yes, that sounds right. Okay, well, we're going to go back through and do some review on those cardiovascular emergencies that do not involve the ACLS based protocols. So we're going to look more at the CHF stuff and things of that nature, and just make sure a lot of the key information, you do have some treatments you can give, but a lot of it, again, comes back down to, do you recognize that signs A, B, and C lead to problem D? That's really what we need to focus on with that. And then, pick up those treatments as they come based on what it is you're looking at. So we'll go over that this week. And if you guys have any questions or need anything, please feel free to reach out to me. Otherwise, we will see you next time.
Thank you, Paula.
Thank you, Paula.
Welcome,
Thanks,
guys.
Paul. I'm
Thank
sorry about
you.
the
Yes.
sorry about the rally traffic. I know
Yep.
it's a nightmare.
No, it's all good. Thank you. I appreciate it. We're just trying to get back.
No.
I gotcha. Well, safe travels to you.
Will do. Thanks.
All right, bye.
Bye-bye.